We will be discussing today Azoospermia, how to proceed. So this is very important topic and very it's usually felt difficult for students to understand how to proceed with a male who has presented with Azoospermia. So let's discuss. Any male presented with the azoospermia, what further we have to do? All these charts have been taken by from the Cambridge Book of Male Infertility, and I will be discussing them. The first and foremost thing any male coming with azoospermia is to examine the palate. If the sperm is present in the palate, it means it is known as cryptozoospermia. Then we will work up the male for oligospermia. Suppose the sperms are absent in the palate also, means the cryptozoospermia is also not there. It is total azoospermia. Then the first and foremost thing is to rule out the vas difference. We have to see whether the vas is present or not. If vas is absent, it automatically makes the diagnosis of congenital bilateral absence of vas difference. But in case the vas is present, the vas difference is present, then we have to measure the semen volume, because the management algorithms are different. In case the semen volume is less, then we have to work up for low volume azoospermia. But in case the volume is normal, then we will be working up the patient for normal volume azoospermia. Firstly, we will be discussing the normal volume azoospermia. The first and foremost thing, whenever the normal volume azoospermia is there in presence of vas, we have to do the hormonal evaluation. Which hormonal evaluation? Follicle stimulating hormone along with the testosterone. If it comes out to be decreased FSH, then it makes the diagnosis of hypogonadotropic hypogonadism, and we have to work up on the lines for hypogonadotropic hypogonadism by ruling out, doing the luteinizing hormone, the prolactin, the pituitary MRI we have to do to rule out the Kalman syndrome, hyperprolactinemia, or any pituitary adenomas. So we have to work upon those lines. But in case it is normal volume azoospermia with presence of vas with normal hormonal parameters or increased FSH, in both cases we have to do the karyotyping, especially if the FSH is more. If FSH is raised, means it is a testicular failure, we have to do with the karyotyping and Y chromosome microdeletions. The newer guidelines, they say if the azoospermia is there in all the patients, we have to take up for the karyotyping and Y chromosome microdeletions if the follicle stimulating hormone is more than 7.6 milli-international unit per liter. In case the karyotype or Y chromosome microdeletions are abnormal or are present, then genetic counseling is done and possibility of sperm retrieval is given depending on the which type of Y chromosome microdeletions are there. We will be discussing these later on, but in short, I will be telling you, if it is azoospermia factor A and B which are absent, then we will not do any sperm retrieval method. Why? Because the probability of retrieving sperm is 0%. But if it is azoospermia factor C, AZFC, then we will be going for the sperm retrieval, because possibility of sperm retrieval is there when there is absence of azoospermia factor AZFC. So we will be discussing in more detail these factors in later on presentation. Then coming on, the karyotype or Y chromosome microdeletion both are normal, but still the FSH is raised. If FSH is raised, it means it is a spermatogenic failure. Then we can discuss with the patient about the sperm retrieval or the adoption or the TTI options. Then if the FSH is normal, when FSH is normal means everything is coming out to be normal, but patient is presenting with azoospermia, then we are left only with the option of testicular biopsy, the FNSC. And depending on that, we will be managing further the patient. Then coming on to low volume azoospermia. Firstly, we will discuss what are the causes of low volume azoospermia. The causes of low volume azoospermia are first and foremost hypogonadism. Anything which leads to decreased testosterone can lead to low volume azoospermia. There can be ejaculatory duct obstruction. It can be seminal vesicle absence or hypofunction, or congenital bilateral absence of vas deferens. So the first and foremost test which we have to do in cases when the patient presents with low volume azoospermia, when vas is present and FSH is normal, is transrectal ultrasound, because we want to rule out any obstructive causes. So this is the foremost test. In case the ejaculatory duct obstruction is present, we see any ejaculatory duct cyst or any swelling then we will work up further on those lines. We will aspirate the seminal vesicle and check for the sperms. If the sperms are present, it means it is the ejaculatory duct obstruction which is leading to panting up of the sperms in the seminal vesicle. And simple transurethral resection of ejaculatory duct, that is turret, that might be therapeutic for the patient. But in case the seminal vesicle aspirate is also not showing the sperms, it means the problem lies in the testis only, and we will work up for the testicular biopsy as we discussed in the previous slide. Then if there is no ejaculatory duct obstruction, then we will have to take the testicular biopsy, and depending on the testicular biopsy, we will manage further. If the testicular biopsy is normal, it means the sperms are there. It might be that somewhere the obstruction is there which we are not able to make out by the ultrasound, and vasography can be done, or simply the sperms which are taken out from the testis can be used for the ICSI. But if the testis is also not showing any sperms, most likely it is a spermatogenic failure, and sperm retrieval options can be given to the patients along with the ICSI. So these were the important the management algorithms in a patient with azoospermia. Thank you.